In this video, we're going to talk about indications for invasive blood pressure monitoring. So I'm going to write here indications. Indications for arterial line placement. So we're going to discuss four main categories for our indications for arterial line placement. And I'm going to divide it here. The way that I like to think about it is just drawing a square here or a cross here, and then we're just going to fill each category with our four indications. So the first one I'm going to write here, and we'll talk about each of these. Think of all the vitals, the big vitals, from an organ-based system. So blood pressure, the heart, the lungs, and then this fourth one we're going to keep wide open here. So our first indication for arterial line is if we are anticipating rapid changes or extreme changes in our blood pressure. So extreme, I'm going to write here extremes of BP or rapid changes. So this could be in highly vascular surgeries. It could be in trauma surgeries where you're anticipating high blood loss, cardiac procedures, which is actually in our next section over here, or neurosurgical procedures where you want to keep a very close eye and you don't on the blood pressure and you don't want to increase your intracranial pressure too high. So needing that continuous blood pressure monitoring is useful in those scenarios and is an indication for placing an arterial line. The next indication for placing an arterial line has to do with the heart. So this involves patients who are intolerant to hemodynamic instability. So I'm going to write here, intolerant to BP changes. So which patients are intolerant to blood pressure changes? For healthier patients, they can tolerate some swings in blood pressure, some highs and some lows a little bit better than patients who are way more sick. The patients who are way more sick and can't really tolerate these blood pressure changes are patients who have cardiac problems. These cardiac problems include severe coronary artery disease, severe valvular disease, and heart failure patients who have severely decreased ejection fraction. So you can take all of this and basically assume that if you have a patient who has severe coronary artery disease, severe valvular disease, or severe heart failure with severely, actually I should break, not preserved, severely reduced ejection fraction, then these patients are likely to need vasopressors. All right, likely needs vasopressors. And anytime you're anticipating that a patient will likely need some blood pressure support or some constant infusion of vasopressors, that is probably a good indication for placing an arterial line. The third indication for placing our arterial line is if you are anticipating severe ventilation perfusion mismatch. Severe VQ mismatch. So if you recall, our N tidal, carbon dioxide, and tidal CO2 gives a pretty good representation of what our PaCO2 is, our carbon dioxide in our arterial blood. And because of that, we can adjust our ventilator settings accordingly to ensure that we maintain an appropriate acid-base status. But if we have so much VQ mismatch then our end tidal CO2 is not going to be an accurate representation of our carbon dioxide in our arterial blood, our PaCO2. So this happens with certain thoracic procedures. So I'm going to write here thoracic procedures, and not all thoracic procedures, but thoracic procedures that require things like single lung ventilation, let's say. That's going to be a severe VQ mismatch. And then there are also certain pathologies, such as if our patient has a pulmonary embolism, or a patient who has ARDS. So if you're taking care of these patients who have a pulmonary embolism or ARDS, it's a good idea to place an arterial line just because your end tidal CO2 may not be representative of your PaCO2, and they have some form, whatever type of form of some VQ mismatch. It's the same thing with ARDS, like I said. The last category does not involve a vital or organ system, but it's basically sometimes in the operating room or given the nature of the procedure, there are going to be some large volume shifts, large electrolyte shifts, and you want to take some lab draws, frequent lab draws, in order to monitor and intervene when necessary. So the fourth indication is frequent lab draws. Frequent lab draws. And like I said, it allows you to assess parameters such as blood gases, such as electrolyte imbalances, fluid status, things like that by drawing off samples in the operating room, and you can do it fairly quickly if you have an arterial line in place as opposed to drawing venous blood and poking multiple times. So indications for arterial line, if you're anticipating extremes of blood pressure or rapid changes of blood pressure, such as in traumas, such as in neurosurgical procedures, and big blood loss procedures. If our patient has severe cardiac issues, such as coronary artery disease, valvular disease, or heart failure with reduced ejection fraction again, and they are likely to need vasopressors. If we're anticipating severe VQ mismatch, such as in cases where we're doing single lung ventilation, or patients have pulmonary embolism or ARDS, where our end tidal CO2 would not be a good representation of our PaCO2. And lastly, if we want some frequent lab draws throughout the case.